Okay, I'd like to introduce our next speaker. She's going to be talking about spina bifida. Debbie Song, pediatric neurosurgeon at Gillette Children's Specialty Healthcare, St. Paul, with a focus on conditions including Chiari malformation, spina bifida, hydrocephalus. She attended the University of Michigan Medical School, Ann Arbor, where she also completed her residency in neurosurgery. Dr. Song is a member of the Congressional Neurologic Surgeons as well as the American Association for Neurologic Surgeons. Please welcome Dr. Debbie Song. The ceremonial handing of the clicker.
Thank you. Thanks for having me here today. Again, my name is Deb Song. I'm a pediatric neurosurgeon over at Gillette. If you guys have any questions during the talk, feel free to ask me during the talk, or you can save the questions to the end. I'm finding a little bit of a cold, so hopefully it won't be too much of an issue. Get started on the clicker. How do I advance? Do I need to? Here we go. So I'm going to talk about spina bifida today. Spina bifida actually means different things to different people. So for the purposes of this talk today, I'm going to use the term spina bifida and myelomeningocele interchangeably. But spina bifida actually, the term refers to a couple different conditions. So you can have spina bifida occulta, which is shown on your left, which is basically where the spinal cord, the nerve roots, the nervous structures are all completely normal. The overlying covering over the spinal cord, the dura and the meninges, is completely normal, but there's a congenital absence of the spinous process, so the vertebral arch and portion of the lamina. Usually it happens in the lower lumbar or the S1 levels. Skin is completely normal, muscle, tissue, all completely normal. So in and of itself, spina bifida occulta is just a congenital absence of a portion of the bone in the spine, clinically insignificant. Up to 20% of the population has spina bifida occulta. And again, it bears no clinical significance unless in some types of spina bifida occulta, in some cases, it can be associated with underlying spinal cord, so-called tethered cord malformations. So if it is associated with tethered cord, then the underlying spinal cord condition is significant. But if you have just spina bifida occulta and no other kind of spinal cord abnormalities, spina bifida occulta completely clinically benign. Then you can have spina bifida, what we call cystica or aperta. Basically refers to cystic dilatation of a portion of the spinal sac. So meningocele is actually a pretty rare condition, but basically you have normal skin, you don't have the normal bone overlying the spinal cord, there's a cystic dilatation of the covering of the spinal cord called the meninges and dura, and then that cystic dilatation is just filled with spinal fluid. So the normal fluid that circulates around the brain and spinal cord, it fills that sac. The actual neural structures, the spinal cord and nerve roots are normal. So you could, despite being structurally normal, up to 1/3 of people with meningocele can have some sort of neurological deficit. So we usually treat that, but we don't have to treat it immediately after somebody's born. Myelomeningocele is pretty much the most severe open neural tube defect, very different from the other two conditions. Most severe open neural tube defect that's compatible with life. So you don't have normal skin, you don't have normal dura or coverings over the spinal cord, you don't have normal bone, you don't have any bone in the back, and you have abnormal, kind of structurally abnormal neural tissue that's exposed through that skin defect. And so that's what I'll talk to you about today, myelomeningocele or spina bifida. And again, I use those terms interchangeably. I don't know. Where do I actually need to point this to advanced?
Let's see if I can help. It should. Jordan.
Working on it.
Okay. I don't know if there's a.
Can you
Or can you advance if I?
Can you advance the slide for us, Jordan?
Give me a second.
The first rule of public speaking is always make sure your AV material works, and I apologize for that. There we go, and he's bringing it back up. The good news is they handle the construction noise.
So, well, we're just waiting for the slide. So, you know, I'm not going to talk too much about embryology at all. So this is the only, go back a slide, please. Or go back 2 slides. maybe I can do that now.
Back to,
While he's working on that, if we think about how does a myelomeningocele occur, so around post-ovulation day 25 to 28, you have a plate of specialized neural tissue called the neuroectoderm that literally needs to fold up and close into the neural tube. And so it doesn't just close up like this, it basically closes up in segments. So basically a portion of it closes and then it's like a zipper, it zips up and down in segments. So at post-ovulation day 28, if the bottom of the tube hasn't closed, then you have part of the tube closed and the bottom part is literally filleted open, and then that lays the foundation for a spina bifida or myelomeningocele. And so, I don't know. Yeah, okay, yeah. So this is just a kind of depiction of, in cross-section, the neuroectoderm, which is a flat plate of tissue, needs to fold up. And this is sort of what happens normally. So next slide. So this is what a myelomeningocele looks like in real life on the right side, and then the cross-sectional kind of depiction is depicted on the left. So basically, is there a laser pointer associated with it?
the laser should work on that. There you go.
It's this thing. Okay, sorry. Yeah.
It might not work on the screen.
Okay, that's okay. So basically, the spinal neural tube is exposed at the skin surface, and instead of being a tube, it's literally a flat plate of tissue. So we call that the neural placode, and that's basically identified right in the center, kind of the glistening red stuff in the center. So that basically placode, that neural tissue, is flat tissue that hasn't rolled up in the spinal cord, and that tissue may still have functional nerve tissue in it. So that's important when we close the back, because you don't want to just disregard the placode and say, oh, that's abnormal tissue. That could still have functional tissue in it. But you can tell that the spine, that the skin is basically not normal above there, and it's really not skin at all. And the bone obviously isn't there. The muscle and the fascia also isn't there. Next slide. So when we talk about sort of who's at risk or why does myelomeningocele occur, there have been lots of different associations with different kind of risk factors. Most commonly that we hear about is folic acid. So in people who have never had a pregnancy affected by myelomeningocele, the risk is approximately 4 out of 1,000 live births. If you've had a prior pregnancy affected by myelomeningocele, then it could go up to 2 to 3%, so 2 to 3 out of every 100 births. If you've had 2 children who've had myelomeningocele, then it goes up to 6 to 8%. And then if mom herself has a form of spina bifida, you can have a risk of as high as 10% in a child. And so in normal women who have not had any kind of history of myelomeningocele pregnancies or have no close relatives or no other risk factors for myelomeningocele, they take usually 400 micrograms of folic acid a day. If you have any risk factors, you take 4,000 micrograms per day of folic acid. We see about 600 patients every year through our Gillette, both adults and children, people in terms of who have spina bifida. And in talking to the parents and the mothers of the children who have spina bifida, most of them have taken normal amounts of folic acid during their pregnancy and really have no risk factors. But you can tell just from this list that there are a whole kind of wide list of risk factors associated with spina bifida. Next slide.
Go ahead and try the clicker.
Okay. Perfect. So diagnosis of spina bifida typically made prenatally, but not always. So it could be made as part of a blood test. So usually around 16 to 18 weeks of pregnancy, mom's blood can be tested, and you can have elevated alpha-fetoprotein. At the 18 to 20 week ultrasound, there are certain findings on the ultrasound that could also be indicative of spina bifida. So one thing that I want to kind of also make clear is that even though spina bifida, it starts out as a neural tube defect at the level of the spine and spinal cord, it has profound implications for how the entire brain and spinal cord develop. So it's really kind of an entirely CNS, central nervous system disorder. So when we look at a ultrasound of a fetus's head, there are certain signs that you can see that are concerning for spina bifida. So this is on a 20-week ultrasound. If you look at a kind of top-down view of the baby's head, if the frontal bones, which are depicted to the right there, if the frontal bones are kind of scalloped in, that's so-called the lemon sign, so that's concerning for spina bifida. If you're looking at a cross-sectional cut through the back of the head, you can see this so-called banana sign, which represents the cerebellum as being pretty tightly wrapped around the brainstem. Thanks. Thanks. When I think about, in my own mind, kind of the neurosurgical issues related to spina bifida, I really divide it into kind of three different kind of steps or categories. So one is the initial stabilization of the neonate born with spina bifida and the closure of the back. Two would be then, shortly thereafter, kind of the assessment and treatment of any hydrocephalus. So that's abnormal spinal fluid accumulation in the brain. And then three would be kind of long-term management of the hydrocephalus and shunt malfunctions moving forward, Chiari-2 malformation, which is an issue with the brain, the back part of the brain, tethered spinal cord, and syringomyelia. And so this is another close-up picture of somebody born with spina bifida. Again, I guess it doesn't work on the screen. The dark gray line is basically the remnant of what's something called the central canal that should sit literally in the center of the spinal cord. The reddish tissue around there is the placode. And then basically when we close a back of a child with spina bifida, I'm having trouble advancing again. Can you advance? Basically, we want to cut around the placode, mobilize the dura, which is going to be kind of filleted open. So we have to close that. So we have to mobilize that element, and then mobilize the tissue, the muscle and fascia around there. So basically, when we, at the level of the placode, we actually close the placode and kind of literally sew it back into a tube, sew up the dura around that, sew up the fascia around there, and close the skin. Actually, at the end, we'll talk about new developments in myelomeningocele, because within the last, I would say, decade, people have really moved towards, actually even less than a decade, really within the last 5 years, people have moved towards potentially closing spina bifida and myelomeningoceles in utero, so fetal surgery at around 26 weeks, and we'll talk about that kind of at the end. So we said that spina bifida and myelomeningocele is really kind of a disease or a disorder that affects the entire central nervous system. So that means that if I look at the brain, if I just look at a brain MRI scan, in many cases I can tell if that person has spina bifida or not, because there are certain brain structural kind of findings that we expect. So one of the common kind of sequelae of myelomeningocele is hydrocephalus. And so normally you have ventricles that are fluid-filled spaces that are that make the spinal fluid. So the top three pictures up here, it's a so-called a coronal kind of face-on view of the brain, a side view, and then an axial kind of cross-sectional cut of the brain. And so those areas in the middle are the ventricles. The ventricles make the spinal fluid, and the brain also has to absorb the spinal fluid again. So spinal fluid is continuously being made, it's continuously circulating around your brain and spinal cord, and it's continuously being absorbed. If your body cannot absorb the spinal fluid normally, then you have hydrocephalus. And so people who have myelomeningocele, many of them have hydrocephalus. And the hydrocephalus is really due to lots of different kind of complicated factors related to the myelomeningocele. It's not an easy kind of X causes Y, but it has to do with kind of irritation of kind of the nerve tissue with the from the amniotic fluid, which can be very irritating and toxic. It has to do with kind of so-called a Chiari-2 malformation that kind of leads to sagging of the brainstem and the cerebellum, and then that could block normal pathways of spinal fluid flow. But regardless, up to 90% of people who have myelomeningocele have hydrocephalus. And so untreated, you can get big ventricles and ultimately pressure building up in the brain. So we typically treat that. So a couple words. Again, 85 to 90% of people with myelomeningocele have hydrocephalus. And I put a little star by there because there is some thought, it's kind of controversial, but there is some trend that for babies that have their backs closed in utero, in the fetus at 26 weeks, the incidence of hydrocephalus is less. And we'll talk about that later as well. So very few babies actually have overt hydrocephalus with, bulging fontanelle, bulging soft spot at birth. So it's very rare that we need to actually treat the back and the hydrocephalus at the same time. We typically like to close the back within 24 hours, and people have done studies, and usually up to 72 hours is okay before you get into the risk of infection. Usually if you are going to develop hydrocephalus, it becomes apparent by 6 months, but sometimes it takes longer. And then sometimes it becomes clinically apparent that you have hydrocephalus, or the hydrocephalus gets worse after you've closed the back, because now you've closed the system. There's no kind of conduit for spinal fluid to leak, and so now you have a closed system, and if the ventricles are under pressure, then that can worsen your hydrocephalus. So the mainstay of treating hydrocephalus is to put a shunt in. There are other kind of procedures that have kind of been in the works that don't have a great track record, but work is still being done, where it's an alternative to shunt, so-called an endoscopic third ventriculostomy. But by far the kind of the mainstay and the workhorse of treating hydrocephalus is a shunt. So the basic configuration of a shunt consists of a catheter that goes into the ventricle, the fluid space. It's connected to a valve that regulates how much fluid flows through the shunt system, and then it's connected to additional tubing that ends in some distal location. So the vast majority of patients that we have, their shunts end in their peritoneal cavity, and then the peritoneal cavity can absorb that fluid. If the belly is hostile, because there's been a lot of adhesions, there's peritonitis, there's one thing or another where the belly is not absorbing, or it's considered a hostile environment, you can also put the end of the shunt into the pleural space, the lining of the lung, or you can put it into the venous system in the atrium. More recently, you can have other kind of less common places. More recently, we had a patient that we had to put it into the gallbladder for. So the CSF drains into the gallbladder and then goes out into the intestines and gets reabsorbed. So for shunts placed at birth, shunts work, but it's a mechanical device. So it can get infected, it can malfunction. And so for shunts placed at birth or in early life, we say about 30 to 40% need a revision by 1 year, about 50 to 60 by 5 years, and about 85% within 10 years will need a shunt revision. And that's not great numbers if you think about it overall. So you will definitely need neurosurgical follow-up lifelong. And then after the first year, we quote about a 5% kind of per year risk of having a shunt malfunction. It's important to know that after the age of 2, shunt malfunction is really the leading cause of death in the myelomeningocele population. Shunt infection is kind of a separate but related kind of problem. Shunt infection is really hard to treat. You basically have to take the entire shunt system out and put a drain in, and the patient has to sit in the hospital for weeks until their spinal fluid clears. Shunt infection is most common if it's going to happen within 6 months of any kind of shunt operation, and then the risks of a primary shunt infection go exponentially down after that. In terms of shunt malfunction, any portion of the shunt can malfunction. Most commonly, it's due to the ventricular catheter that's going into the ventricle becoming plugged. So the shunt catheter is actually a hollow tube with a closed tip, and it has a couple of holes along the sidewall. And so if those holes become plugged with tissue, because it's not just fluid or spinal fluid in the ventricle, there's actually tissue there, but if that tissue plugs those holes, then that can lead to either a partial or a complete obstruction of flow. So these are pictures of just literally ventricular catheters that I've taken out of people's ventricles, and it looks like literally a trail of snot coming out of the catheter. It's important to know that when we work up somebody who we think might have a shunt malfunction, their ventricles may or may not enlarge. So typically, you have the ventricles on a CT or an MRI scan, and then you think that if the shunt is plugged or it's not working, the ventricles will get bigger, bigger, bigger. That happens in about 70% of people, but about 30% of people, their ventricles don't change at all. And so that can make diagnosing a shunt malfunction a lot more difficult, but there are ways that we can get around that and diagnose it. It's also important, there are mimickers in the myelomeningocele population of shunt malfunction. So you can see ventricular enlargement and all the signs and symptoms of shunt malfunction commonly in people who have really bad constipation. So people with myelomeningocele, they don't have normal bowel or bladder sensation. So they have neurogenic bowel and bladder. They can have a lot of constipation. They can have frequent clinically symptomatic urinary tract infections. All that kind of increases your intra-abdominal pressure. So if you think about the shunt system, there's a valve that regulates how much fluid flows through the shunt. If the valve has to sense a pressure difference between the peritoneal cavity and between the brain cavity, and so let's say my shunt valve has to sense a 5-unit pressure difference. That means if my brain pressure is 5 or greater, and my peritoneal pressure is 0, then fluid will flow through the shunt. But if you have constipation, if you're in a urinary tract infection, if you're pregnant, anything that increases your intra-abdominal pressure is no longer 0, it could be 10. And then the pressure in your brain has to go to 15 or greater for fluid to flow through the shunt. And we'll see a picture of that in a second. Seizures are also not a common manifestation of shunt malfunction, but you can have, if there's a change from baseline of somebody's typical seizure patterns, that can also be associated with ventricular changes. So this is a patient that came in, I think, from out of state. I think he saw one of my partners for the first time, and we had no outside records on him. The kid, ventricles were not tiny, not huge, but the family was saying, oh yeah, he has all the kind of, his classic symptoms for shunt malfunction. So we get an x-ray, and there's a bunch of, so the first x-ray is on the left. And so that's the shunt tubing in the belly. And you like to see the shunt kind of freely mobile, like very broad loops in the peritoneum. But you can kind of get the sense that the shunt tubing is all kind of pushed up into the right upper quadrant. And there's a fair amount of stool there. So basically, he was admitted, we didn't rush him off to surgery or anything like that. Got a very aggressive bowel clean out. And by like the next day, the end of the next day, you can see how his shunt tubing looks a lot happier. It's not pushed up, it's kind of freely coiled, and his shunt system is essentially resolved. You can also have problems with failure of absorption of fluid. So you can have big pseudocysts that are shown. This is abdominal CT. You can see at the very top, the little white dot is the shunt tubing, and there's a big fluid collection around there. So if you've had a lot of abdominal surgeries where there's a lot of scarring or adhesions, or you have a low-grade infection, the CSF may not absorb, and then you'll get basically a big pseudocyst, so that's a problem. If you have a pleural shunt, you can get big pleural effusions. And so this is somebody, top right, who had a pleural shunt in, and this is kind of an immediate post-op x-ray, and he comes in months later with essentially a whiteout. And so that's a problem. So you have to find a different than distal terminus. So there are common signs and symptoms of a shunt malfunction. Typically we talk about headache, nausea, vomiting, but they could also be very subtle. It could be kind of a low-grade change in cognitive function. In the myelomeningocele population, we'll talk about other conditions called tethered spinal cord and Chiari, where you could have kind of motor changes, bladder changes, tone changes, spasticity, that you would think would be related more to kind of spinal cord issues, but they could all be a manifestation of shunt malfunction. So a common kind of theme is that in particularly the spina bifida population, if we're ever thinking about doing something surgically for any other thing other than the shunt, we always have to make sure that the shunt is working. In infants, where their skull is still pretty pliable, the symptoms may be different. So they may have just a rapidly increasing head circumference. They may have kind of a bulging fontanelle. They may be more irritable. In the NICU, you could see more apneas and bradycardias. Particularly for people who have ventricles that don't change with size, getting a yearly eye exam is very important. So if we see papilledema, which is kind of pressure at the level of the brain that is transmitted to the optic nerves and the optic discs, then until proven otherwise, that's an issue due to high pressure and a shunt malfunction. So we treat those pretty urgently because untreated, they can lead to blindness. The shunt is a mechanical device, so even though the ventricular catheter, that being clogged, is the most common cause for shunt malfunction, older shunts can also break. And so you can have scar tissue that forms around a shunt catheter, and with time that shunt tubing and that scar becomes kind of brittle, calcified, and as you turn your neck, it can actually fracture. So the right, I don't know if you can see it very well, but basically there's a catheter that's fractured at the level of the neck, and then, the left, and the right is where the shunt is fixed. And you can kind of tell on the sort of the bottom beyond the break on the right side that the shunt tubing looks thickened and kind of irregular, and that's kind of degenerative tubing, and that happens to everybody with shunts that are 10, 20, 30 years old. Occasionally, we'll see people who come in, particularly to the adult clinic with spina bifida, and they're doing fine, and we get just a routine shunt series, just x-rays to look at their shunt, and lo and behold, their shunt is broken. And so then that raises a question, can you ever become shunt independent, and do you really need a shunt? And that's a pretty complicated question to answer. Most of the time when we're putting shunts in, we put them in with the intention that you'll need them for the rest of your life. But there are people that do fine without their shunt functioning. And as the flip side of that, there are people that do fine for years, 5, 10, 15 years, and then suddenly at a different point down their lives, they seem to have all the signs and symptoms of a shunt malfunction or high pressure, and it turns out they need their shunt. So there are different ways that we can assess whether somebody truly needs their shunt. Are they having any symptoms? Are their ventricles getting larger on a follow-up scan? Do they have papilledema? And if all the answers to those are no, and they're still doing fine, we can do so-called a dye study, where we basically inject a little bit of nuclear medicine radioactive tracer into their shunt reservoir and see, does it actually flow through the gap that's in their shunt tubing. So if the shunt tubing is broken, we said that breaks because there's really dense scar around there. But even if the tubing is broken, there'll be still a scarred track. And so fluid can actually cross that track. So if we do a dye study and it shows that there is still tracer moving across that break in the scar, that tells us that the person probably needs a shunt, because spinal fluid is going to be traveling through that shunt scar and that break. And so that's the safest thing to do. If the tracer were to stop right at the break and not cross that gap, then we feel more confident that you probably don't need your shunt. Okay, I might need, can you, okay. So there are different ways that as clinicians we can assess shunt function. One thing, again, in the spina bifida population, easy thing to do outside of the hospital is to do an aggressive bowel clean out, because pretty much everybody with spina bifida will have some degree of constipation due to the neurogenic bowel. If they have a urinary tract infection, treat that. If they have underlying viral illness, treat that with supportive fluids. So common thing is diarrhea is a sign of a GI bug, not a symptom of shunt malfunction. From a clinical standpoint, we can get imaging. We can get a shunt series just to make sure that the shunt is intact, it's not broken, it's not kinked. We can get imaging of the ventricles. But again, in 30% of people, even with a shunt malfunction, their ventricles won't change. We can tap the shunt. We can put a little butterfly needle into the reservoir and assess the patency of the shunt. And that only assesses the patency of really the ventricular catheter. And that's not a perfect study either, because ideal shunt tap is you stick a needle into the reservoir and then you get free fluid of spinal fluid into your tubing. If you have to aspirate a little bit, what does that mean? If you have to kind of really aspirate and hold aspiration, that means something else. So shunt tap is not a perfect study, and the shunt tap really usually cannot assess distal, like valve or distal tubing function. We can do a dye study, a nuclear medicine study, the kind that we just talked about, to assess kind of the flow of the fluid through the shunt tubing. And then completely separate from the shunt, if we're concerned that somebody may have shunt malfunction symptoms, but their imaging is really stable and things aren't really making sense, before you go operate on the shunt, the other option is just to stick a little wire in a place of the brain separate from where the shunt is to literally monitor, are the pressures high or not. That also is not a perfect thing, because some people they do better at lower pressures, but you can at least tell, is the pressure normal, low, high. The dilated eye exam, for the reasons we discussed before, is also very useful. If we see papilledema, that's concerning. Sometimes something that we also use is a trial of what we call Diamox or acetazolamide. So that's a medication that can temporarily reduce the production of spinal fluid. So if you give somebody a 7-day trial of Diamox and they say, oh, my shunt malfunction symptoms, my headaches all got better, that suggests that potentially that there is a shunt problem. So moving on from hydrocephalus, Chiari-2 malformation. So we said that spina bifida really is a pan-CNS kind of condition. So up to 90% of people, 80 to 90% of people who have spina bifida that's closed postnatally will have a Chiari-2 malformation. And that's basically a condition where part of the brainstem, the cerebellum, and the fourth ventricle basically sag down into the upper cervical spinal canal. And you can see that on the right side. The left side is basically the side view of a normal brain. And so you can see basically the brainstem, the cerebellum, all contained within the skull confines. And in Chiari-2, again, the brainstem is abnormal. And then there are other brain anomalies associated with the Chiari-2. But basically brainstem, the fourth ventricle, and the cerebellum are all abnormal, and they're kind of sagging into the upper cervical spinal canal. And so why does that happen? It's thought that when you have the open neural tube defect and you're chronically losing CSF through that defect, The brain normally, if you didn't have that defect, when the brain develops, the brain has to kind of become distended, but it has to see a kind of a back pressure. And so if the pressure in the spine, in what we call the subarachnoid space, is too low because the spinal fluid is leaking and the brain doesn't have any kind of back pressure to kind of push against on, the skull will actually develop abnormally, so that the area for the skull to sit in, or for the cerebellum to sit in, becomes too small, and the brain also doesn't develop normally. So when we talk about later on the fetal closures, it's thought that if you close the back early, before they're born, around 26 weeks, even if you have a Chiari-2, that Chiari-2 can actually reverse, and so the incidence of Chiari-2, because now you have a closed system with the fetal repair, becomes much less. We said that shunt malfunction is the leading cause of mortality in somebody with spina bifida over the age of 2. So in the infant population, Chiari-2 malformation and sequela is really the kind of the leading cause of mortality, because basically you have brainstem issues, you can't swallow well, you have breathing issues, you could have vocal cord paralysis. So the things that we see in the neonates who have really severe Chiari-2 malformations, apnea, stridor, inspiratory stridor, swallowing difficulties, they can have lower cranial nerve problems. And so oftentimes this is a population of people where in the young neonates, if they're facing a tracheostomy, before that we will do a Chiari-2 decompression to try to improve things or optimize things. But there's also another kind of group of neurosurgeons out there who really believe that even if we do a Chiari-2 decompression, the brainstem itself is abnormal, so that bodes very poorly, and so people may still not do well despite the Chiari-2 decompression. Like any other kind of neurosurgical intervention, before you do any kind of Chiari-2 decompression, you have to make sure that the shunt is working. But I will say the vast majority of people do not need a Chiari-2 malformation. It's something that we see on the MRI scan but does not require intervention, really. So again, the only population that I really would consider it in is the young neonates, where they have significant kind of vocal cord problems, where they're facing a tracheostomy. Moving on, tethered cord and myelomeningocele. So basically, if you think about, we said you have to close the neural tube again, you have to close the dura over that, and you have to close the skin and soft tissue above that. So there's always going to be some degree of scarring between the level of the spinal cord and nerve roots at the level of the closed placode and the overlying dura. And so 100% of people who have spina bifida will have radiographic tethered cord, where their spinal cord will look like it's kind of stuck to the dura. And when you grow, or when you, in an adult, when you kind of have trauma, repetitive trauma to that area, that can cause symptoms. And so basically, you think about spinal cord stretching during growth, the bony vertebral column stretching and the spinal cord stretching, and if it's tethered or scarred at the bottom, that can cause issues due to tethered cord. So on the left side, you see a normal spine MRI, lumbar spine MRI, and on the right side, you can see somebody with spina bifida. So their spinal cord is low-lying. It doesn't end at a normal position. Normally, your spinal cord ends at around the lumbar 1 level. So in spina bifida, you don't have normal bone. The spinal cord is low-lying, and it looks like it's stuck to kind of the dural sac. So again, 100% of people with spina bifida radiographically will have tethered cord, but only about 30 to 40% of them will actually need a surgery for it. And so we go by clinical symptoms when we think about tethered cord surgery. And really the symptoms fall under 3 categories: neurological, so it could be simple as pain, usually during growth spurt in the back of the legs, worsening muscle function. So that's why when we see people with spina bifida, we are oftentimes getting manual muscle strength testing on a yearly basis with our physical therapist. If you see a decline in manual muscle strength testing by a grade or 2, that's concerning. If you see increased muscle tone spasticity, that's concerning. So neurological symptoms, orthopedic symptoms, so worsening neuromuscular scoliosis. If you have kind of worsening foot deformity despite orthopedic surgery, that things are getting worse, or kind of recurrent deformity in the feet or in the hips, that's concerning. And if you have worsening urological function, so bowel and bladder. There's no good way to test bladder or bowel function. Bladder function, the urologist can do urodynamics, and they can basically track kind of bladder function. So if you have a growth spurt and you have kind of worsening neurological, orthopedic, urological kind of function, that argues, in favor of a tethered cord becoming symptomatic. And again, in kids, the symptoms are driven by a growth spurt. So this is somebody with scoliosis. So more there's a little bit of controversy. So if somebody has just scoliosis that's rapidly progressive in spina bifida, and you can see their curve there, and that needs to be corrected or else they're going to run into kind of respiratory issues. And so this orthopedic surgeon, the spine surgeon, wants to literally straighten their spine. That's going to effectively lengthen their spinal column. But at the same time, then if your spinal cord is tethered and they're really stretching the spinal column, that potentially could have implications on your spinal cord and function. So there's some variability in terms of how aggressive people are. I will say at our institution at Gillette, we're pretty aggressive. So if somebody is going to need a big spinal fusion and they have a myelomeningocele, usually about 6 to 8 weeks at least before the spinal fusion, we'll go in as neurosurgeons and untether the spinal cord. And so what does untethering mean? Basically, we want to kind of free the spinal cord and the nerve roots from the overlying scarred dura. And it's not a necessarily straightforward operation, because if things are really scarred in and you can't even tell by the imaging really the degree of scarring, sometimes they're picking at the spinal cord and the nerve roots. And there are ways that we can prevent kind of neurological compromise, but we say really about 5% risk of worsening neurological function, and in about 2.5% those neurological deficits from surgery are permanent. With any tethered cord release, we have to make sure that the shunt is working as well. And tethered cord is actually pretty effective. So it's really effective. It usually resolves your pain. People can tend to get stronger after that, as long as the weakness has not been there for too long. And bladder function improves in about 50% of people. So just a word for adults. So we said in kids, we do tethered cord releases because it's really driven by a growth spurt and the stretching on the spinal cord. So in skeletal immature people, you could still have tethered cord syndrome. It's a lot less frequent. And usually it's not driven by growth because you're skeletally mature, but it's usually driven by kind of repetitive trauma, and particularly florid flexion. The difference in adults with tethered spinal cord is that surgery is a lot less effective, but on the flip side, medications are more effective. So NSAIDs and steroids can actually be very helpful. I was trying to find some pictures. So this is just a case I did a couple of weeks ago. This is, I think, about a 6 or 7-year-old girl with rapidly progressive scoliosis. So she, I think just about 2 weeks ago, got her spinal fusion. She also had some bladder deterioration. So basically left side is towards the head, right side is towards the legs. It's a kind of a view looking down at her spinal cord. And this is kind of taken midway through the case. So you can see bottom will be her left side of spinal cord and nerve roots coming off. So it gives you the visualization of the nerve roots coming off the left side of the spinal cord. Right side is towards the top. The black lines are sutures holding the dura open. And you can just, we're about halfway through and we can see, the scarring, particularly towards the right side, the spinal cord and the nerve roots. And so literally we just want to free that up. And then there's a follow-up picture. I might need. Can you help me advance one over? Any luck? There's one more. There, and so, one back, sorry. And so that's basically the after, you can kind of tell, I have an instrument basically kind of circumferentially around the cord and the bottom of the cord and the nerve roots. And that's kind of what we want to achieve. So moving on. Syringomyelia. A syrinx, or the condition of syringomyelia, represents spinal fluid collected inside the spinal cord. So we said that spinal fluid is normally around the spinal cord, inside the sac, the dural sac, but it's not normal to have spinal fluid inside of the spinal cord. And so if you see that, that's called a syrinx, and the condition is syringomyelia. Incredibly common in people with myelomeningocele, so you could see it in anywhere from 40 to 80% of people with spina bifida, but only about 2% of people are symptomatic. So this is another kind of issue where, yes, you'll see a radiographic abnormality, but we don't do surgery unless there's really been a really significant clinical deterioration, and we think that the symptoms are related to the syrinx. So on the left side is is just a normal spinal cord. Right side, you can see somebody with spina bifida, you can see their Chiari-2, but you can see also the big kind of distension in the spinal cord and the white kind of sausage appearance of the syrinx. The spinal cord is actually being kind of really distended out by the syrinx. A lot of the symptoms of syrinx, if it happens in your cervical and thoracic spine, will overlap with either tethered cord or Chiari-2. So sometimes it's a little bit difficult to kind of tease the symptoms out. There are different ways to treat a syrinx. Again, most syrinxes do not need to be treated. We can put a little stent or a shunt into the syrinx cavity itself. We can do a Chiari decompression, or you can do a tethered cord releases. And all those operations have been used to treat syrinxes. But again, the main thing is before you do anything, you need to make sure that the shunt is working and functional. So proof of principle of that last point. This is a patient formerly seen by somebody else and had an MRI of the spine years ago, which did not show a syrinx. Then I think about 2 years ago, had an MRI of the entire spine to assess scoliosis, and has that little syrinx in the upper cervical cord. And then basically I did a shunt revision on her because she was going to need a tethered cord release. So we did the shunt revision first. And then a follow-up MRI scan, you can see that the syrinx is essentially gone. Can you advance one more? The case, or the picture that I showed you from the slide before, or 2 slides before, but if you advance one, that would be good. So that was a patient of mine with spina bifida who had a lot of issues with the shunt, but we finally got the shunt, the hydrocephalus under control and the shunt working well. And that patient had a high lumbar spina bifida, so does not walk, does not have any voluntary movement of the legs, but can sit independently. And so the physical therapist said, with time, he used to be able to sit independently for 10 or 20 minutes, and now he's sitting really for a minute, and then he kind of loses balance, and he's getting weaker in his left hand. And so really, you don't want somebody who really has no functional leg movement to begin with to lose function in their arms either. And so with time, we slowly, we tracked his syrinx for a while, and then with the word of the physical therapist, and then kind of, you can see on the left and the middle picture, that's sort of how his syrinx evolved. And then we just made a decision, yes, let's treat it. And so I did basically just put a little stent, a little piece of tubing into the syrinx cavity itself. So you have to make an incision on the back, open up a little bit of bone, open up the dura, make a little cut into the back part of the spinal cord, and actually slip a little tube into the syrinx cavity. And then the other end of the tube is sewed to the underside of the lining underneath the dura. So the spinal fluid basically drains from the syrinx cavity to the normal spinal fluid space around the spinal cord. And so on the right, you can kind of see the results. So the syrinx has gone down significantly. And there's a little faint black line on the very bottom. I don't know if you can see it or not, but that actually is a syrinx tube that you can see. So you can't really see it on the top right, but you can see it kind of on the bottom. So final thing I wanted to talk to you about is that kind of what's new on the myelomeningocele front. And so in 2011, there was a study published in the New England Journal of Medicine called the Management of Myelomeningocele Study, so MOM study. It took 8 years to complete the study. And again, the thought was, if we see that there is an open neural tube defect and there's all these bad things that happen, the bad toxic amniotic fluid is kind of affecting how the spinal cord develops, if the spinal fluid leak that's kind of chronically there during pregnancy, if that's affecting kind of brain development. If we close that defect as soon as possible, where it's still feasible and safe enough for mom and baby, will that kind of improve your function? So there were 3 centers, basically, all the pediatric neurosurgeons got together and said, we're only gonna let 3 centers do this in a very controlled fashion. So it was Vanderbilt, CHOP in Philadelphia, and UCSF. And basically they looked at primary outcomes. So at 1 year they looked at death or shunt placement. And then at 30 months they looked at cognitive and kind of motor level. And so there are 2 deaths in each group. Shunting is somewhat controversial because if you see a baby with big ventricles, but is otherwise doing okay, maybe a little bit delayed, then the question becomes, at what point should you put a shunt, or should you put a shunt in? If they're not deteriorating by any means, but they have really big ventricles, then it's a difficult decision. The question becomes like, would they benefit, and in which way, from a shunt? Would they be cognitively better? Would they be developmentally better with a shunt? And sometimes that's a very difficult question to ask because shunts have lots of problems associated with them. So they had clinical criteria for which they said, okay, you have hydrocephalus, you need a shunt. And so basically they said about, I think it was like 50% or 50 to 60% of people in the fetal group that got their back closed in utero reached that hydrocephalus criteria, 90% in the postnatal group. So a significant difference. It ends up 40% of the people in the fetal group got shunted, 80% in the postnatal group got shunted. So it's still a big difference. But there is some bias of holding off on shunting somebody, and I think that bias it still exists today, even now. It's a difficult decision to make, and I'll show you a picture in a second of kind of an example of that. Cognitive function, really at 30 months, no difference. There is some thought that at 30 months, we saw 40% of people in the fetal group walking, 20% in the postnatal group walking. But as we've gone longer and longer out from that study, probably that's more of a wash. So at 30 months, the difference is not a durable difference. But what we see is definitely a difference in Chiari-2, the incidence of Chiari-2. So in somebody who has their back closed postnatally, about up to 80% of people have really moderate to severe Chiari-2 malformations. Only about 1/3 of people who have their back closed intrauterine or in utero will have Chiari-2 malformations that are significant. So the actual principles of closing the back are pretty similar. This is sort of some real life pictures. But there are certain risks associated with this. So the biggest risk is preterm labor. So we're seeing people now, the latest you can deliver with an in utero closure is 37 weeks. So if people consider term 38 weeks, the latest you will go with an in utero closure is 37 weeks, and then you have to deliver. But now we're seeing more people who have had fetal closures that are being born at 30, 32, 33, 34, 35 weeks. So not only are they dealing with myelomeningocele and spina bifida and all the issues related to that, but now you have a portion of them who have cerebral palsy. So these are 2 MRIs taken from 2 different patients who have had fetal closures. And I think what you can tell for sure is that if you look at the very bottom of the brain, the Chiari-2 malformation on the left side really isn't there. On the right side, it's kind of there in a very mild form. And so both of these patients had their backs closed in utero. On the left side, ventricles may be a little bit prominent, but not huge and does not require a shunt. The right side, basically also part of the study and kind of really big ventricles. And the question is, she's developmentally delayed motor-wise, but not having excessive irritability or anything like that. But we kind of slowly watched her ventricles get bigger, 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 bigger. And again, at what point do you put a shunt in? So I ended up putting a shunt into her, a couple months after this MRI scan, but it's still kind of a hot topic in pediatric neurosurgery. So just final thoughts. I think that any clinical deterioration in somebody after kind of the infant stage really requires evaluation. But a common theme that we talked about, you have to assess the function of the shunt, because a shunt malfunction can mimic all the signs of a tethered cord, of KRI2, of a syrinx that's symptomatic. So fixing the shunt or making sure the shunt is working before proceeding with any other type of neurosurgical intervention is important. And again, imaging will show abnormalities, so we never make the clinical decision to do an operation based on imaging, but it's really at kind of if there's a change clinically. And again, spina bifida patients will require lifelong neurosurgical follow-up. And not only neurosurgical follow-up, today we've talked about really myelomeningocele in the context of neurosurgical issues in the green bubbles. We didn't really talk about kind of the long-term orthopedic, urological, kind of rehab implications, and also the psychosocial and cognitive kind of effects that these people have. So, long-term, people have done studies, even if people's IQs are normal with myelomeningocele, about only 30 to 40% of people are living independently. So that raises a whole new set of questions and concerns. That's about all I had to say today. Are there any questions?
I know I learned more about spina bifida than I ever thought possible. and now I know there's more I need to learn, so thank you very much. So if there are questions, again, you can write them in the cup, or if we have time for one. Otherwise, we'll thank you very much.
All right, thank you.
Appreciate your